so that I can introduce everybody. Mehul?
Yes, ma'am.
Are we good to go?
Okay. Yeah, sure. Okay. So on the behalf of Corona Remedies Private Limited, I, Mehul Doradia, welcome all the delegates and faculties for the Core Connect live webinar, Public Awareness Committee, FOXY with North Zone, which is initiated by the FOXY and Public Awareness Committee with Badlav Team. So it's my great pleasure to invite Dr. Monica Umbardhan. And I request to the madam that madam, please proceed this webinar and take this to the newer heights.
Yeah, thank you, Mehul. I welcome all the esteemed faculty to the 16th session of the Public Awareness Committee Core Connect webinars. As we all know, August is the Breastfeeding Awareness Month and September is a Nutrition Awareness Month. Taking into consideration these two themes, we have designed today's webinar where we have focused talks on breastfeeding and nutrition in pregnancy, as well as a panel discussion on anemia. This session is the brainchild of our chairperson, Dr. Priyankur Roy, who is the chairperson of the Public Awareness Committee. We hold these sessions every 15 days with respective zones. Mehul, can we have the inauguration slide, please, first? As we begin, we take blessings from Lord Almighty. I request all the faculties and our guests of honor, Dr. Kamal Bakshi Madam. No, 1 minute, please. Yeah. Dr. Kamal Bakshi Madam and Dr. Chandravati Madam, who have consented to be the guest of honor today, to join us for the inauguration ceremony. Can you please play now? Thank you, Mehul. We now move forward. I take pleasure in introduction of Dr. Rishikesh Pai sir, our President FOXY for the current year as a chief guest. Sir had consented to be, but he's traveling to Greece and he's on his way, so he will not be able to attend the program. But he has sent his blessings and best wishes for this program. Now I take privilege in introduction of our guest of honor, Dr. Kamal Bakshi Madam. Anita ma'am, can you please introduce ma'am?
Yes, it's a great honor. Thank you so much, Dr. Monica, for giving me this opportunity to introduce one of the best jewels and gems in the field of Obs and Gynae, and also the best human being I have come across, Dr. Professor Kamal Bakshi ma'am. As you all know, she has been the head of the department of the most prestigious institute, AIMS Delhi, and she has taken care of lakhs of patients and so many students she has produced who are now very well doing in our FOXY. And ma'am is Padam Shri also, she has been awarded. She's a very decorated person. And now she's just like, mother, a friend, a sister, everything to us. So I think this is what I like to say about ma'am. Thank you, ma'am, for being here with us. Yeah, since ma'am didn't want, so I didn't read everything about her because she has so many awards, Life Achievement Award, everything, every other day. She's going on getting also, every other few weeks we hear ma'am is getting this award. So we are always inspired by you, ma'am, and keep blessing us.
Thank you very much. Thank you very much. Dear Anita, Dr. Monica, and everybody. Good evening, dear friends and colleagues. It is indeed a great day for me to see you all. And I tell you, it makes me so rejuvenated to see you all and to put our mind, heart, and soul on this most vital and critical subject of nutrition. We have with us who's traveling to Greece, the most dynamic, energetic, enthusiastic president, Dr. Pai. And he has a lovely team, Madhuri Patel But Dr. Roy, whose brainchild, as far as who is the chairperson of the awareness committee, it is always a pleasure to meet to him. Now, as far as we are concerned, and that all of you have been creating awareness among the young doctors, patients, and family on the significance of what to eat so as to beat the diseases. But today, I am very thrilled and excited, and as you have seen, to see Dr. Chandravati, the Doyen, a living legend in the field of obstetrics and gynae. अगर उसने किसी को कहा ट्रेन रुक जाओ तो क्या ट्रेन क्या प्लेन या पब्लिक भी रुक जाएगी क्योंकि उसके जैसे डॉक्टर बड़े कम मिलते हैं. My namaskar to my pyari Dr. Chandravati. Meet my old friend Dr. Ritu Khanna. What a charming. She has the beauty and the brains, and a great academician. And we have with us from Kashmir, Afzal. Wow, a young dynamic girl. और कश्मीर तो इतनी सुंदर जगह है कि उसके पहाड़ों में उसकी सुंदरता को देख के and lovely fruits. And then now to see this, I would say with Preeti, Anita Sabarwar, Shivani, Jyoti, ये यंग बच्चों को देख के तो लगता है कि बाहर आ गई, चार चांद लगा दिए आपने. It is so nice. Now, as far as I am concerned, that who are our greatest VIPs, who are the persons who need nutrition? It is the infants, the newborns, the children, and the adolescent girls who are going to be the future mothers, And as far as the pregnant women is concerned, the pregnant woman is the most neglected person, and she has to cook, do all the work. And if she's a doctor, to go to the hospital, no food. And little do people realize that she is the one who's carrying the fetus, and where, as far as the everything, the angiogenesis is occurring, the microbiomes, the DNA component, the immune system, all things are forming. And if we do not care of this embryo, and this all starts on the 5th day of having the sex, when the egg and the, as far as the semen meet to form the embryo. So the nutrition of the pregnant women improves the health of the nation, and it is the wealth. Our army people, our everybody. But as far as I am concerned, I am really upset as far as the farmers are concerned. हर वक्त झंडा ही लहराते रहते हैं, पर farmers, they add pesticide and don't even look after as far as the soil is concerned. And then people who sell the vegetable, टमाटर में भी तेल लगा देंगे, बैगन में भी तेल लगा देंगे, or they will inject, and I've seen people injecting. And when I visited INA, my goodness, flit leke taki makhi meat or fish pe na aaye. And then आपने देखा होगा विद्या दूध में यूरिया डालते हैं ताकि बढ़िया पनीर बने. मैं कहती हूँ all these people, strict punishment should be given because this is very harmful. And I would say that you young brand can be the leaders, that we have the good diet as far as the diet is concerned, and you are our wealth partners. So mera pyara namaskar, and thank you for making me the part of this family. Pranam.
Thank you so much, ma'am. I request Priyankur also to extend thanks to ma'am and invite our next guest of honor.
Thank you, Monica. So good evening once again. Kamal Bakshi ma'am, it was a pleasure listening to you as it is always. Thank you so much for the wonderful comments. It's always pranam from all of us to you, ma'am. We really regard you really high, and this is such a motivational statement that you passed. Thank you so much for that, ma'am, and thank you for joining today.
Thanks.
So I welcome all of you to yet another Core Connect program of the Public Awareness Committee, and this time we are with the North Zone. We would of course like to thank our President Dr. Rishikesh Paisa, Secretary General Dr. Madhuri Patel ma'am, and Dr. Alka Pandey ma'am for all their support that they always extend. I would like to thank Dr. Kalyan Barbade, the National Coordinator, as well as Monica and Dr. Shatabdi for being there for all the programs and coordinating it so very well. And special thanks to Dr. Anita Sabarwal ma'am and Dr. Vidhu Modgil ma'am for being the conveners. They have always been very supportive, and Anita Sabarwal ma'am especially has been ever supportive for all our programs and all our endeavors. Actually, the first program that we had done was a physical program with Dr. Anita Sabarwal ma'am in Delhi. Thank you so much, ma'am, once again. So I would now like to invite our guest of honor, Dr. Chandravati ma'am, who is another source of inspiration for most of us. So Chandravati ma'am, can we have a CV, please? So Chandravati ma'am, as we all know, is a patron of Lucknow Obstetrics and Gynecology Society, and I would rather say a patron of the entire Foxy as well. She is a professor emeritus at the Department of OBGYN at the KG Medical College in Lucknow. She has been the chairperson of the AICOG brilliantly conducted in Lucknow 4 years back. And she has been the president of a number of societies, including the Lucknow Obscurity Society. Ma'am, it has always been a pleasure listening to you. We would like to invite you to say a few words of blessings for everyone present here today.
Thank you, Priyankur. I was really thinking if anything is done and Priyankur doesn't invite me, it is not possible, because every time I'm there with these all programs. Thank you. Thank you, Monica, for being kind enough to have me here, because it is a wonderful platform to meet even Kamal Bakshi and so many of you here today on this platform. I'm so happy that Public Awareness Committee has decided to join hands with the North Zone and run this today's webinar with having significant numbers of members from North Zone, and all sparkling smart people are there today's program. The topic chosen by you, both the topics and the panel, all are very, very essential for the good initiative for the pregnant mothers. And you have chosen Ritu for the macro and micronutrients in the pregnancy, and Dr. Afzal for the baby-friendly hospital. And I know Preeti how she is going to conduct the anemia panel, because she is going to really reach to the grassroots level of the anemia treatment and diagnosis, what she has been doing for such a long time. I wish you all a great success for today's webinar. I'm sure people are going to really gain lots of knowledge today from your webinar. Wishing you all a best and best of today's program. Thank you.
Thank you so very much, Chandravati ma'am. Always a pleasure listening to you, and thanks for blessing everyone for this webinar, and always. Thank you so much again. So now, as ma'am has said, the scientific session, we would like to welcome the speakers, Dr. Ritu Khanna ma'am and Dr. Asma Afzal, as well as the chairpersons, Dr. Vidhu Modgil, Dr. Amita Gupta, Dr. Dinesh Pathak, and as well as Dr. Jyoti Malik. So welcome all of you. For the panel today, we have Dr. Preeti Kumar ma'am and Dr. Anita Sabarwal ma'am, who will be the moderator, and the expert is Dr. Kavita Bhatti. We have our brilliant panelists today, Dr. Anupama Bahadur, Dr. Vartika Kishore ma'am, Dr. Gargi Munjal, Dr. Parul Gupta, Dr. Rastogi, Dr. Nidhi Agarwal, Dr. Gayatri Singh, as well as Dr. Shivani Sachdevkar. So thank you so much for all of you for agreeing to this session. And before I hand over the session to Monica for conducting the scientific session, I would like to just inform you one thing, that you can see probably the number of participants is showing us 15, but this number of participants, 15, are the faculties and they are not the delegates. We have approximately around 350 delegates logged in now. So I think this is itself is an inspiration for us to continue on behalf of Public Awareness Committee for all the programs that we do. So over to Monica to kindly go ahead with the science. Thank you once again.
Thank you, Dr. Priyankur. I would like to extend my thanks to Chandravati madam and Kamal Bakshi madam for gracing this occasion, and I declare that the inauguration is over. We now move forward to the scientific session. Our chairpersons for the first session are Dr. Vidhu Modgil ma'am and Dr. Amita Gupta madam. Dr. Vidhu madam is also the convener of the North Zone Public Awareness Committee programs. She is a director and senior consultant at Suman Hospital, Ludhiana. She has received various awards, including the North Zone UA Foxy 22, the organizing chairperson of the IAG Punjab chapter. She is also the Manya coordinator in Punjab, a member of the Presidential Task Force team, the best student and a gold medalist in surgery. She has received the Nari Shakti Award also. We welcome you, ma'am. Our next chairperson for this session is Dr. Amrita Gupta, madam. She is formerly the professor and head of the Department of OBGY at the SMGS Hospital, GMC Jammu, the officer in charge at HRCC under ICMR. She has been an undergraduate and postgraduate examiners in various universities. She is currently the secretary as well as the past president of the Jammu OBGY Societies. We welcome you, ma'am, and we request for the chairpersons to please conduct the scientific session and invite Dr. Ritu Khanna, madam, as a speaker for the next talk. Amita, ma'am, please unmute yourself. Hello?
Good evening, everyone.
Yes, ma'am. Yes, ma'am.
And Madam Ritu Khanna, she's a very sweet person. And as Madam Kamal Bakshi has told, that beauty with brains. And recently, we had a chance to see her in Varanasi, where there was a conference. So she's a very senior gynecologist and teacher also. I welcome Dr. Ritu Khanna. Madam, please deliberate on your topic.
Can I just thank you so much, madam, for those kind, loving words. And also my thanks to Dr. Monica, Dr. Priyankar, and of course, Dr. Kalyan, who's there with us and has given us this opportunity to be with you on this platform. And my gratitude and warm regards to our mentors, Dr. Kamal Bakshi, madam, and Dr. Chandravati, madam, who are the energies behind us. And it is their inspiration, I think, which keeps us going forward. So with this, I begin my presentation on role of macro and micronutrients in pregnancy. The mother and the baby both being benefited. It's a 9 months, and the months are the windows of opportunity. Not only the windows of opportunity, preparing us to fall in love for a lifetime. So what happens is, there are 4 miracles of the babies which are going to happen when they're born. It's a physical growth, it's a cognitive development, it's an immune maturation, and a digestive maturation. So what does this mean? It means that because pregnancy is a part of those 1,000 days from the conception to the child's second birthday. So it gives the optimum health, the growth, and the neurodevelopment just to be established in this child's life. So the foods eaten before, during, they help her to prepare for the growth of the baby. And a sensible eating gives the baby the best chance of a healthy beginning. Yes, we need calories, but from where do they come? We have the macro, we have the micronutrients who are going to go and take her the healthy way around. But the question is, how much and what should be taken? So your healthy meal should be something like this, And this is a plate which has the 5 food groups, the vegetables, the milk and dairy foods, cereals and grains, meats, beans, and eggs, and also fats and oils. But the proportion should be the one that is shown in this plate. But when she's just eating, how are we going to assess? We're going to see the weight gain of the mother, the blood reports, and also we keep doing a serial ultrasonography to assess this growth. But what is the weight gain that should the mother have? It depends all on the BMI before the pregnancy. If she's a normal, she has an 11 to 16 kgs of weight gain. If she's underweight, she needs a little more, and that's 12.5 to 18. But if she's overweight, it goes to a lesser side, and that's 7 to 11.5. And if she's obese, more than 30 BMI, she needs to gain less than 7 kgs. So now this first trimester, we really need to take care, because now this is the time of a very, very rapid cell division. So what are we going to do? We're going to prepare for the cell division as well as a preparation for the extra demands that she'll need during the 2nd and the 3rd trimester. Now the 6 weeks baby, just the size of a pea, and 7 to 8 weeks, the amniotic sac, the placenta, they're just developing. So do we need so much of calories? No, we do not, or we need very little calories at this time. So what do we focus our attention on? And that's to peak our attention on the proteins, on the folic acid, the B12, and the zinc that are going to be required. So pregnancy is not eating double of what you eat. It's about adding just a few extra calories and some of the essential nutrients that are going to really nourish your baby. So when you move into the 2nd trimester, the baby started to hear The organs, 6 organs are growing, the hair growths are going to come, and maybe some hiccups. So now this mother needs to take more calories. How much more? It's 340 kilocalories per day extra, apart from the protein and the iron. She needs calcium, magnesium, B, and omega-3 fatty acids. Now, if you move into the next trimester, now the 6 organs are getting matured. How fast the brain is developing, and the bone and the tooth growth. So what do you need? You need a little more, 120 kilocalories, much more, that's 450 kilocalories extra. So along with the protein, iron, calcium, magnesium, vitamin B and omega-3 fatty acids needs to be a little more than she was in the second trimester. Now the macronutrients, they are macro because you need them in large quantities and they're going to provide you a lot of energy, and we know it's protein, carbohydrates, fats, fiber and water. But on the other hand, yes, this energy is going to be supporting the fetal growth. But on the other hand, we cannot miss, and what is that? That's a micronutrient. It's an umbrella term, and we need to put under them the vitamins and the minerals. And are they going to provide us energy? No, they're not going to provide us energy. Then what do we need them for? We need them for a normal cellular and a molecular function, the cell signaling, the motility, proliferation, differentiation, apoptosis, and thereby all your tissue growth, function, and hemostasis will be regulated. We all know of the macro and the micronutrients. To mention some, what are going to be the effects? Folic acid, we know the neutral tube defects. Iron, anemia. Iodine is cretinism. And calcium is hypertension, PIH. We need to be alert about them. Zinc is anemia and low birth weight. Vitamin A is a vertical transmission, or the infant survival, or maternal anemia and infections. Now, if you just pick up the macro ones, you get energy. It's going to give a proper fetal placental growth. Yes, and it's going to build DNA and the special cells which are really going to make up your immune system. But I need to take 60 to 100 grams per day of this protein. Just put this chart in front of you and it's so easy. Yes, this I need to take if I'm a veggie. And if I'm a non-veg, I need to take eggs, meat, and fish. I'm a veg, I need a lot of soyas, I need a lot of sprouts, grains, seeds, rice, and milk and dairy products. The carbohydrates, the greatest source of energy. And all these carbohydrates are going to break into simple sugars like glucose. And what are they going to do? It's going to just now pass very easily across the placenta and thereby give energy to the growing baby. So the recommendation is 175 to 200 grams per day of these carbohydrates. Now we need whole grains, we need potatoes, we need brown rice, oatmeal, bananas, cheese, and soft drink and sweets. Of course, to get all these carbohydrates and along with egg, meat and fish, you need some amount of seafood if you're a non-vegetarian to get these carbohydrates. But always keep an eye on all the good carbohydrates and keep a note to all the bad carbohydrates, and these pictures need to be in front of us. So no donuts, no ice creams much, no potato chips, cereals, but go on to sweet potatoes, oats and brown rice and beans and lentils. Fats, yes, they provide 25% of the energy for the fetal growth, and the brain marvelously growing, or 80% of the brain growth is going to be there. So you need to take fats as 25%. But be careful that you need to take the unsaturated, because if you take a lot of saturated fats, they're going to lead you to preeclampsia, to GDM, or a preterm delivery. And we also know monosaturated and polysaturated fats, olive, nuts, avocados, nut butter oil, and ghee are the mono, and the poly are the nut seeds, sunflower, and mayonnaise, etc., which we can take. Water. We need to take at least 2 to 3 liters of water to have a good digestion. It's going to maintain the amniotic fluid. And the best is, it is a very, very good detoxificant. So that's going to help you to remove all the unwanted materials which you're having over there. The fibers, yes, the fruit and the berries is a must. You have to consume a single fruit a day. That's necessary in the grain and the green vegetables. And so it's going to keep your heart healthy. It's going to decrease the risk of diabetes and also decrease the risk of preeclampsia. Now, if you look into fetal stunting, it's largely caused by maternal inadequate nutrition right from conception to the first trimester. And if you go into more data, it's been found that 50% of the growth failure is because of pure nutrition to this mother, both during pregnancy as well as before pregnancy. So certain tips, just prioritize. You take whole foods instead of processed, instead of juices, and vary your veggies, which include green vegetables. Take at least half of your grains as whole grains. Take low fat or fat-free versions of dairy and opt for lean, healthy protein sources. If you come further to the micronutrients, we know with vitamin D, there could be a neonatal hypocalcemia. Vitamin K for hemorrhage. Copper would lead to anemia, anencephaly, or a low birth weight. Selenium, we never thought of. It's so important for the neural tube defect and the brain dysfunction. Magnesium has now gained a lot of importance for the blood coagulopathies, toxemia, and preterm births. If we come back to our micronutrients, we have the iron, yes, the red blood cells, we have a good panel on anemia, and we really know the importance of this iron, which is going to expand the blood volume. Spinach and iron fortified whole grain breads are going to be a very good source, and it's required as 27 milligrams per day. These are all the iron-rich fruits, which I think Dr. Preeti is going to take, and we're going to just put all of them into all our clinics so that every patient knows what to take. The folic acid, blood and protein production is dependent on it, and the enzymatic function is lots dependent on folic acid. It's going to prevent your neural tube defects. You need a lot of spinach, green vegetables, and even iron-fortified whole grain breads. Yes, you require it as 600 micrograms per day. So now these are the foods. Sometimes we feel like taking broccoli, yes, and cauliflower, beets, bell peppers, beans, peas. They're all very, very rich in folic acid. And don't miss a papaya, again, a source of folic acid. So now calcium and D3, we know we need strong bones and teeth, and D3 needs to be supplemented just as to increase the absorption of calcium. So we can take milk, cheese, yogurt, very tasty, spinach, and of course, don't miss the sunlight. And the fortified foods we have are wonders that we can get vitamin D3. So calcium is 1200 milligrams per day, and vitamin D, as the guidelines say, for 2000 units per day. So if you come to iodine, yes, the thyroid function, the neurological development, the mental retardation, we cannot afford to have any of the babies who are neurologically deficit or mentally retarded. So we need to supplement, and we must know that in pregnancy, at least there's a 50% increased need for iodine. The spinach, milk, berries, and we've got fortified salts, and all the other foods shown over here are very, very important sources of iodine. Zinc, we needed to as maximum as 34 milligrams per day. But why? Why do we need zinc? We need it for our cells to divide, for our tissues to grow, to decrease preterm birth, to decrease the prolonged labors. So we could have beans, nuts, whole grains, and oysters and red meat, which are good sources of zinc. Selenium, yes, 70 to 80 micrograms. We're going to reduce the risk of preeclampsia and preterm labor if you're going to supplement them. So do not miss your second trimesters. Of course, be supplementing them with selenium and magnesium. Magnesium is required as 350 to 400 milligrams per day, and that's to improve the fetal growth, to prevent preeclampsia. And we also must understand that sometimes the studies say, yes, they're looking at mitral valve prolapse. It's looked as a collagen disorder now, and it's simulated with Marfan syndrome. And this is associated with magnesium deficiency. So yes, we cannot afford to have all these. So why not supplement with magnesium? Vitamin A, as 800 micrograms per day, we need it for the embryonic growth during the early period of pregnancy. Vitamin K is not needed during pregnancy except those who are on anti-seizure medications where they're yet on a risk of vitamin K deficiency in the fetus. So oral vitamin K 10 milligrams per day from 36 weeks to delivery would be needed by these patients who are on the anti-seizure medicines. So there are more than 300 enzymes and whose functions can be impacted. If your diet is going to be deficit in what? And that is manganese, magnesium, zinc, and copper, but we cannot afford to miss the enzymatic function, so we need to supplement. So let's see, is micronutrient supplementation really necessary during pregnancy? Yes, because insufficient source are going to have a lot of negative implications. And what are these? This woman is going to suffer from anemia, hypertension, so many labor complications, stillbirth, preterm deliveries, and so it's very, very crucial also for the fetal development. Not only this, it serves as cofactors and coenzymes, so we cannot miss them. We need antioxidants to fight against free radicals, and so there is an exponential rise of the micronutrient requirement during pregnancy. If you take the micronutrients, folate, B6, B12, choline has picked up so well now, and methionine from the dietary protein, they all interact and they maintain the level of homocysteine and regulate DNA methylation. So epigenetic process, including this DNA methylation, is going to just modify the phenotype outcomes. And so it's going to affect the long-term effects of health and disease. So FIGO recommends on adolescents, preconception and matricial nutrition, says, think always nutrition first. If you look into vitamin D and the active form, it adjusts the transcription and function of genes. And where are these genes going to be associated? They're associated with the normal implantation, the invasion and angiogenesis. So if they are deficit, they're going to lack the normal implantation, and therefore it's going to produce an abnormal immune response in the pregnant woman. And also there are going to be increased chances of inflammatory reactions or hypertension. And micronutrient deficiency is going to lead to FGR and modification in the phenotype of the baby. So how does it affect? It's going to affect the programming for the future metabolic diseases in the adult life. And that's the importance. So whenever we're going to put our patients in the outline of the management of toxemia, we need to give them diet rich in whole grains, fruits, vegetables, sugar sweetened beverages and all. Why? Because if you take the management of hypertension in pregnancy, it's not only the drugs, you need the micronutrients. And look at this chart, which shows that yes, you need to supplement to lower the risk of hypertension during this pregnancy of the patient. So if you just open your hands and you decide what I need to give this patient in pregnancy, it's going to be 6 servings of whole grains and proteins. It's going to be 4 servings of veggies and fruits and 3 servings of daily dairy milk products. So mothers do not need to eat for 2, but what do they need to do? They need to think for 2. And what is the thinking? The thinking is the quality of diet, which is the key, and it's a challenge for nutrition during pregnancy. So if we look what we need to eat, there are 10 food groups, and the 10 food groups are all these which are displayed. So what you need to do is you can pick up these 7 food groups, and out of these 7, select the 5 groups that you need to take, and then your plate is going to turn up like this. But look at the lines in the plate. Look at the protein and the whole grains, and how much is the non-starchy vegetables and the fruits, and this is going to be your pregnancy plate that your patient needs to take. But what is unhealthy? Unhealthy is the junk food. It's an irregular meal time. It's a craving for a food. She wants some drinks. She's taking some high-fat foods, some processed foods, some processed meats, some caffeine. So this is all healthy. So then what are the tips for a healthy eating during pregnancy? Never forget your breakfast. Eat foods which are high and rich in fiber. Choose healthy snacks. Take a prenatal vitamin with iron and folic acid. Stay away from the soft cheese and lunch meat. Limit caffeine and avoid alcohol. Drink a lot of water. Keep yourself hydrated. So good nutrition with micronutrients. So many issues could be prevented. Westernized diet is going to add you imbalance and risks, so just avoid it. And mother has to be equally happy. But why is it? Because pregnancy is a part of those 1,000 days, which are really, really crucial. Nutrition now matters forever for her. So if you eat well, you find that even your children would be eating well. So your prenatal diet is no much more important than any supplement you would ever take. So thank you so much for a very patient hearing.
Thank you, Madam Khanna, for this elaborate talk. And really, you have covered very well macronutrients as well as micronutrients and their importance. And now it is very well understood and oftenly said that your diet during pregnancy will decide the behavior of the individual later on. The diseases like cardiovascular diseases, diabetes, hypertension, they all start in the womb. So we really have to take care of the diet of the mother during antenatal period, and which is the responsibility of the gynecologist attending the patient. Thank you, everyone. And I hand over to Dr. Priyanka, Dr. Monica, please.
Thank you so much, ma'am.
Monica ma'am, thank you for sharing the session. And Ritu ma'am, it was an excellent presentation which has covered almost all the topic points for nutrition in pregnancy. Thank you so much, ma'am. We now request to move on to the second scientific session, which is a talk by Dr. Asma. The chairpersons for this session are Dr. Dinesh Pathak sir and Dr. Jyoti Malik ma'am. Can we have their CVs, please? Dr. Dinesh Pathak sir is working as a senior divisional medical officer in the ANR Divisional Hospital, Firozpur, Punjab. He is the president of the Firozpur OBGY Society, the founder secretary of this same society with special interest in high-risk pregnancies and maternal mortality. He has been a part of scientific programs for various conferences and received the CMD award twice for excellent work in the Northern Railways. We welcome you, sir. Our next chairperson for today's session is Dr. Jyoti Malik Madam. She is a medical superintendent at the JJ Institute of Medical Sciences at Bahadurgarh. She is also the director of Roots IVF and Fertility Institute, JJMS. The Secretary General.
Thank you, Dr. Monica. I think we'll move on to our scientific session. Thank you so much.
Definitely, ma'am. You can move ahead, ma'am. Dinesh sir can introduce Asma ma'am, and you can sum up the talk, ma'am.
Okay. Yeah, thank you. Can I have the slide, please? Yeah, good evening, everyone. Dr. Asma Madam, she is a associate professor in Government Medical College, Srinagar. She is a consultant at LDH Hospital. She has got a special interest in high-risk pregnancy and placenta acquita spectrum disorders. So, welcome, Dr. Asma ma'am. It's up to you for your talk. Nice talk.
And Dr. Asma would be talking on baby-friendly hospital initiatives. So a very useful topic and very burning topic, actually. So over to Dr. Asma.
A very good evening to all of you. It's a great pleasure to be here with all of you in this webinar. I'm thankful to Public Awareness Committee, FOGSI, especially Dr. Monica, for giving me opportunity today to give a talk. So I'll be speaking on baby-friendly hospital initiative.
Asima, click on the slide and then it will move. Click on the slide, huh? Yes.
Oh, thank you, ma'am. So it's a baby-friendly hospital initiative. It's a global initiative that was launched in 1991 by UNICEF and WHO to promote, protect, and support breastfeeding. Main aim was to support breastfeeding. So for the hospitals to earn baby-friendly hospital award, they must show that they have adopted certain practices to support breastfeeding. Today, more than 20,000 maternities in the world are fully implemented. They have fully implemented the 10 steps of breastfeeding and have been certified by the Baby-Friendly Hospital Initiative. During this time, exclusive breastfeeding rates have also increased significantly. Now, what are the goals? Goals of Baby-Friendly Hospital Initiative: to transform hospitals and maternity facilities through implementation of the 10 steps. And the other goal, to end the practice of distribution of free, low-cost supplies of breast milk substitutes in the maternity wards and hospitals. Now, the core purpose, what's the core purpose of this initiative is that what is the role of facilities that provide maternity and newborn services? They have to ensure that the mothers and newborns receive timely and appropriate care before, during, and after their stay in a maternity and newborn facility. They have to enable the establishment of optimal feeding of the newborn. Families of the newborn, they must receive evidence-based information and counseling about breastfeeding and protection from commercial interests, and they should be protected from the commercial interests that negatively impact breastfeeding. Now, what are the 10 steps that are that were given by the WHO for successful breastfeeding? Every facility providing maternity services, care for newborn infants, they should follow these 10 steps to successful breastfeeding. Step 1, have a written breastfeeding policy that is routinely communicated to all healthcare staff. Number 2, train all healthcare staff in that's necessary to implement this policy. Number 3, inform all pregnant women about the benefits and management of breastfeeding. Number 4 is help mothers initiate breastfeeding within usually half an hour to 1 hour of birth. Point number 5 is that they have to show mothers how to breastfeed, how to maintain lactation, even if they have been separated from their infants, because of sometimes the infants get admitted to the nursery. So they should not stop producing breast milk. They should be still continuously produce breast milk so that when the baby is discharged, they can feed the baby. 6th point is that give newborn infants no food or drink other than breast milk unless medically indicated. Number 7 is that practice rooming in. Allow mothers and infants to remain together 24 hours a day. Encourage breastfeeding on demand. Point number 9 is that no artificial teats or pacifiers should be given to the breastfeeding infants. And point number 10 is foster the establishment of breastfeeding support groups and refer mothers to them and after the discharge from the hospital or clinic. These 10 steps that were given by WHO and UNICEF, they were revised in 2018, and the revised points are there, 1 and 2, they deal with providing an enabling environment for sustainable implementation within the facility, and points number 3 to 10, they delineate the care each mother and infant should receive based on evidence-based interventions. Now we have the point number 1. 1 is further divided into A, B, and C. 1A, we have to comply fully with the International Code of Marketing of Breast Milk Substitutes and subsequent relevant with World Health Assembly resolutions. There should be no promotion, display, advertising of company logos, no gifts, free samples, or subsidized samples provided of the infant food, this milk substitutes, and no donations, coupons to be given, no pics of mother and baby with the brand, no sponsorship, any conflict of interest. There should be no commission, and they should provide accurate information. Step 1B, they should have a written breastfeeding policy that is routinely communicated to all healthcare staff. The breastfeeding policy, it should be written in the most common languages that can be understood by the patients and staff. And it should be available to all staff caring for mothers and babies. And it should be posted or displayed in areas where mothers and babies are cared for. Then 1C is the establish ongoing monitoring and data management system. Sentinel indicators are early initiation of breastfeeding and exclusive breastfeeding. Integrate recording and monitoring of clinical practices into quality improvement systems. There should be meeting of clinical staff at least every 6 months to review the implementation corrective actions. And there should be also survey of the maternal discharges. Then point number 2, this is the revised this point. It's according to this, ensure that staff have sufficient knowledge and competence and skills to support breastfeeding. The healthcare staff should get practical training to implement 10 steps of breastfeeding. They should be taught the skills needed to assist the nursing mothers for expression of breast milk and correct positioning during breastfeeding. They should be knowing about the advantages of breastfeeding. They should explain it to the mothers, what are the advantages of breastfeeding, what are the risks of artificial feeding, what are the mechanisms of lactation and suckling, how important is it to make the baby suckle, how to help mothers initiate and sustain breastfeeding, and to resolve, and if there are any difficulties the mother is facing during breastfeeding, they should be able to resolve those difficulties. Discuss the importance and management of breastfeeding with pregnant women and their families. This all is to be done in the antenatal period. Importance and benefits of breastfeeding, they should be told about the importance and benefits during antenatal period. What are the various recommendations for breastfeeding? Importance of early initiation, skin to skin contact, early feeding cues. What is the position of breastfeeding? How to attach the baby to the breast? What is the risk of formula feeds? What are the other challenges? And sometimes there are special circumstances. How to manage those circumstances during breastfeeding? What is the importance of feeding on demand? And how do working women have to breastfeed? What are the ways they can collect their breast milk and keep it refrigerated or at room temperature to feed the baby? And how to prepare nipples. Nipples should be prepared during the antenatal period. Sometimes many patients, they have nipple problems like inverted nipples or other problems, and they have to be prepared during the antenatal period. Then point number 4 is facilitate immediate and uninterrupted skin to skin contact and support mothers to initiate breastfeeding as soon as
I think she lost connection.
Yeah, we have lost Dr. Afzal, I think. Maybe.
Monica, can you call her?
I will just call her up right now.
Jyoti ma'am, in the meantime, you can sum up the session, sum up her session. I will just call in case if she's able to join right now. Otherwise, we can start with the panel discussion, ma'am.
Okay. Yeah. First of all, my best wishes and thank you for inviting me, Dr. Priyankur, the chairperson PAC, and Dr. Monica, who is the in charge PAC activities of FOXY. And this is actually a very nice initiative by the Public Awareness Committee of FOXY that has been taken. And we have been speaking on this BFHI, that is the Breastfeeding Health Initiative that Dr. Afzal was talking about. So I don't think there is anything that stops us, any institute or any health facility. It can everybody can get this certified BFHI because it is so very easy and it just needs a little more preparation from our side and training the staff. I think just if we can train our girls, our staff, and during antenatal care, if we can talk to the patient and prepare them mentally about breastfeeding, I think it is a very, very easy thing that one can do. And the 10 points that she has covered are very easy to follow. And basically, we are all being driven by this commercial preparations. And that is why we are not able to achieve this initiative. And I am sure if we follow each and every all those 10 points, I think it is a wonderful thing. And breast milk is the best milk, actually. It is not only good for the baby, improving the immunity of the baby and protecting from so many other diseases, but also for the mother. Breastfeeding is such a wonderful thing. One can
There is early involution of the uterus. It prevents PPH. It gives those contraceptive advantages to the mother later on, and also it prevents against breast cancers. So I think breastfeeding initiative is something which we all as obstetricians should take up, and the PSC committee has very nicely taken up this topic. And I think now ma'am has joined, I suppose.
Yes, ma'am, she has
Sorry, ma'am,
joined
my
back.
internet
So
connection was
Yeah.
interrupted.
Sure, ma'am, you can
Dr.
continue,
Asma,
ma'am.
please continue now.
Am I
Yeah.
audible now?
Yes, yes.
Yes, ma'am.
Okay, thank you. So, fourth step is that we have to facilitate immediate and uninterrupted skin-to-skin contact and support mothers to initiate breastfeeding as soon as possible after birth. And usually within half an hour to 1 hour of birth, baby should be breastfed. Regardless of the mode of delivery, uninterrupted contact should be there for at least 1 hour. And we have to ensure that baby gets the colostrum. And we have to offer help if needed. Any type of help we have to give to the feeding mother, lactating mother. Early initiation of breastfeeding, it increases the duration of breastfeeding. It allows skin-to-skin contact for warmth. It gives warmth to the baby, especially in cold places, provides colostrum as the baby's first immunization, and babies learn to suckle more effectively, and it also results in improved developmental outcomes. Then number 5 is the support mothers to initiate and maintain breastfeeding. They have to initiate it and they have to maintain then it and manage common difficulties. Practical support, including emotional and motivational. We have to individualize attention, especially attention is more needed by the primiparas who have delivered for first time, LSCS patients, because they have pain. They are in pain usually in the post-operative period. It's difficult for them to sit and feed the baby. They need special attention. And obese patients, those with multiple pregnancies and who have low birth weight babies, preterm babies, they need more individualized attention. And we have also to teach them how to express milk. In case there is a problem, they need to express milk. We have to teach them that thing also. Then point number 6 is that we don't have to provide breastfed newborns food or fluids other than breast milk unless medically indicated. We have to encourage exclusive breastfeeding for 6 months and continue for at least 2 years. There may be some medical reasons where breastfeeding may not be advised. Otherwise, we have to continue breastfeeding. Medical reasons, it can be baby infant related conditions, like there can be galactosemia or maple syrup urine disease. There can be phenylketonuria, or some infants for whom breast milk is the best feeding, but we have to they may need formula in addition. Like, for example, macrosomic babies who are at risk of hypoglycemia, they may need in addition to that formula, or very low birth weight infants or very preterm infants. Breast milk is the best option for them also, but sometimes we may have to supplement them also. Then we have to enable the mothers and their infants to remain together and practice rooming in 24 hours per day, 24 hours whole throughout the day. They should be in the same room day and night, and the mother has to do responsive feeding on demand, and if not, have medically justifiable reasons for being separated, be with baby, give practical help. Mother should be given help in case of LSCS because she is not able to sit properly. And if the baby is admitted in the nursery, there should be no restrictions to visit the baby, and staff should also ensure that babies are safe. Then support mothers to recognize and respond to their infants' cues for feeding. There should be no scheduling or restriction on frequency or duration. When the baby is separated, Support the mothers, visit the infant as often as possible, and recognize feeding cues. When staff notices feeding cues, bring the mother and baby together. Regardless breastfeeding or not, respond to needs of feeding, comfort, and closeness. Then point number 9 is counsel the mothers on the use and risks of feeding bottles, teats, and pacifiers. Can affect sucking, feeding cues, and milk supply. If expressed milk, we have to teach them how to feed with cup or spoon feeding. Sometimes syringe may be needed for feeding, sometimes droppers may be needed, and they also should be knowing about the hygiene risks, and they should make an informed choice of the feeding method. We have to discuss with them the disadvantages of pacifier, teats, and bottles. We have to coordinate discharge so that parents and their infants have timely access to the ongoing support and care. Support can include early postnatal clinics or for checkup, home visits, or telephonic calls, or community services, outpatient breastfeeding clinics, peer counseling programs. There can be mother support groups or family support system. All these can support breastfeeding. UNICEF and WHO has also given a baby-friendly hospital initiative for small, sick, and preterm newborns. As we all know, small, sick, and preterm newborns are at increased risk of early growth retardation, infectious diseases, developmental delay, and death during infancy as well as childhood. Human milk and breastfeeding, they are extremely important for these fragile infants to decrease morbidity and mortality, and also support the best possible growth, development, and overall outcome. Routine implementation of the 10 steps to successful breastfeeding to promote, protect, and support breastfeeding in this vulnerable group should become the standard of maternal and neonatal care worldwide. If unable to fully feed at the breast, feeding of expressed breast milk, donor human milk, or if unavailable, infant formula may be needed for these infants. Appropriate feeding methods, for example, feeding tubes, cups, bowls, spoon, dropper, syringes may be needed. Use of bottles and teats negatively affects breastfeeding in preterm infants. Therefore, cup or tube feedings, if needed with progression, slowly progression to the breast is recommended. And proper planning should be done after the baby is discharged. Thank you.
Yeah, thank you so much, Dr. Asima. You very nicely covered about this BFHI. There are some concerns actually. Normally on day 1 or 2, sometimes the mother are not able to produce so much of milk. So how do we counsel the mother, and how do we help them in such a situation?
If the mother is not able to produce milk on day 1, day 2, they should be properly counseled. They should be explained the mechanism of breastfeeding. Only when the baby will suck, only then there will be release of hormones, and there will be this formation of milk. With that only, so that the sucking is very important. Some patients say that baby doesn't suck, I cannot feed, my milk is not coming, but we have to make them understand that only if the baby sucks, that is the mechanism how breast will be formed. So they have to be patient. So they have to continuously put the baby to the breast so that milk is produced. And in case baby is getting hypoglycemia, not getting proper feeds, they can use the supplements that time for a short period of time. And at the same time, they should put the baby to the breast so that the breastfeeding mechanism, what is the mechanism of milk production, that will go and the breast milk will come after 2 or 3 days. Quantity may.
Absolutely. So basically, we have to be more sort of keep on counseling them and
Yes,
putting the
counseling is very
baby
important
to
in
breast is the
breastfeeding.
most important thing, because nipple, as soon as the baby suckles the nipple, then only the
Get formed.
messages go to the brain to release oxytocin, and then the initiation of breast milk starts. So that is very, very important, and we don't, and some that is what these mothers don't do at that particular moment. So very, very nice talk. Thank you so much.
Can I add one sentence?
Yes, ma'am. Yes, Dr. Preeti, ma'am.
So,
Absolutely.
very nice talk, Asima. I think baby-friendly hospital initiative is very, very important these days. Can you imagine what percentage of mothers feed baby within 1 hour of the delivery? Can you just imagine? The government data in UP shows only 28% of the women after delivering are feeding their babies within 1 hour. So that's one of the biggest challenge. So what we did through Manyata, we tried to create baby, breastfeeding corners. In every hospital, a breastfeeding corner was created where, all the IC material was put in, and where pregnant women was, counseled before when she was pregnant itself during antenatal period, how you should feed your baby. So this is one of the very crucial step, not only for the government of India, but also for every state. I'm not talking about the states like Kerala, where the mortality is less and where the health statistics is much better. But states like, Assam, Uttar Pradesh, Bihar, Jharkhand, Haryana, Rajasthan, these are the states where still only 28 to 30% women feed their babies within 1 hour. So every healthcare worker and every doctor should take an initiative that the breastfeeding should be initiated within 1 hour of the delivery. So whether it is a cesarean, at least put the baby on the breast, some action should start, what Asima was telling, breast suckling should start. And if there is an acute emergency or there is any other problem, that's another thing. But breastfeeding should be, it should be a motto of each and every OBGYN that we should initiate breastfeeding within 1 hour of the delivery. That's just what I wanted to add.
I'd like to add one thing.
And also, yeah.
Most of the time, whatever the initial 1-2 days, there is only cholesterol. So the mother should be counseled that the
regarding the
white color milk will only appear on 3rd day or 4th day.
That's very
important. They should not worry. They should ask whatever their parents are there with them, or whoever is with them. They need to counsel them also, because they are the first person who to worry too much, and they will create so much ruckus that they will feed the baby from top feeding. So they will not stop. They'll say the baby is not taking feed, baby is crying again and again, and they will force or they will hide and they will feed the baby.
Yes.
So it should be stopped by the staffs that this should not occur, and this should be counseled. Not only the mother, but all the relatives also should be counseled at the same time. That's it. This should not be done. So then only it will be successful. And one more thing, that during our initial antenatal examination period, we should always examine the nipple and breast. Always, we should make it a habit, because most of the what happens that after delivery, what you find, there is inverted nipple, retracted nipple. So there's a problem. So we are not able to ask them to how they will feed, and then it's all the motor is fails. So if we can identify the detected nipple, then we can make it using the suction or whatever the visibility is there, so that the nipple can be inverted and make ideal for the breastfeeding. Thank you.
When they most of them will just put in the nipple part only, the teeth part. So they should be explained that whole of areola must go in. Otherwise, they
when
keep
this
doing
data
that.
was presented by the pediatric department of KGMU, Anandi Bain, the governor of Uttar Pradesh, immediately asked them who is at fault. Because if 80% of the deliveries are happening in the government institution, then who is at fault if you're not able to feed the baby within 1 hour of the delivery? So I think every OBGYN from this platform should take this initiative forward, what Asima has told, that breastfeeding is very, very important, not only for the baby, but also for the non-communicable diseases, both for the mother and the baby. So excellent deliberation. So we can move on to the panel now.
Yes, ma'am. Thank you so much, Chairpersons Dr. Dinesh sir and Jyoti ma'am, and thank you Asma madam for a excellent talk. rooming in and kangaroo mother care also should be explained to the mother, ma'am. And IEC, the posters could be put up in the ward where people can, when the mothers are sitting idle, they can read the benefits of colostrum as well as breastfeeding. That could be one thing that also helps. I now request Dr. Shatabdi to please conduct the next scientific session.
Thank you, Monica. Thank you, Dr. Asima. That was indeed a very, very crisp discussion, I would say, crisp talk, I would say. We would move on to our panel. We have a panel today on case-wise approach to anemia, where our moderators are Dr. Preeti Kumar ma'am and Dr. Anita Sabarwal ma'am. And the expert for the panel is Dr. Kavita Bhatti ma'am. Can I have the slide, Mehul? Yeah. Dr. Preeti Kumar ma'am is the chairperson of the Safe Motherhood Committee of FOXI, committee member of MFM committee, as well as joint secretary of the India Gestosis chapter and co-chair of the maternal and perinatal committee of SAFOG. Ma'am is the professor and head of department of Obstetrics at Narayana.
Shatabdi, you can move ahead.
Yes, ma'am. Welcome, ma'am. Welcome, Dr. Preeti, ma'am. Yeah, our next moderator for the day is our very own Dr. Anita Sabarwal, ma'am. Ma'am is the North Zone coordinator for the Public Awareness Committee of FOXI, president of the FOX, that is the Forum of Obstetricians and Gynecologists of South Delhi.
Thank you, Dr. Shatabdi.
Yeah.
Thank you.
Welcome, Anita, ma'am.
Thank you.
Our expert for the session is Dr. Kavita Bhatti, ma'am. Kavita Bhatti, ma'am, is currently the professor and head of department of Christian Medical College and Hospital at Ludhiana, Punjab. Ma'am is the member of Practical Obstetrics Committee as well as the member of Medical Education Committee. Ma'am has various awards and recognition to her credit. Welcome, Kavita, ma'am.
For the introduction.
Yeah.
Thank you.
Our we have elaborate panelist with us. Our panelists are Dr. Anupama ma'am. Can we have the slides, please, one by one, Mehul? Yeah. Dr. Anupama ma'am is the professor and unit head at the Department of OBGY at AIIMS Rishikesh. Ma'am has various achievements to her credit. Her special areas of interest are reproductive medicine, infertility, minimal invasive surgery, medical education, and high-risk pregnancy. Welcome, Anupama ma'am. Our next panelist is Dr. Vartika Kishore ma'am. Ma'am is the past president of the Mathura Obs-Gynae Society, member of the Safe Motherhood Committee, advisor of the Adolescent Health Committee, as well as the Manyata trainer of project under SMC FOXI. Welcome, Vartika ma'am. Our next panelist is Dr. Gargi Munjal ma'am. Ma'am is a senior consultant at Sri Balaji Hospital, Sirsa, as well as the ex-associate professor at Maharaja Agrasen Medical College. Special expertise, she has a special expertise in minimal stimulation or natural cycle IVF. Welcome, Gargi ma'am. Our next panelist is Dr. Parul Gupta ma'am. Ma'am is the director of RK Medical Center, Lucknow, as well as the consultant, senior consultant obstetrician and gynecologist. She has been the organizing committee member of national conferences like IAGE and Gestosis. Her specializations are infertility and high-risk pregnancy. Welcome, Dr. Parul ma'am. Our next panelist is Dr. Shivani Gaur ma'am. She is the director of SCI IVF Hospital, clinical research fellow at Imperial College and Hammersworth Hospital NHS Trust. She is featured in the Limca Book of Records, as well as the vice chairperson of the Women's Doctor Wing of IMA South Delhi. Welcome, Dr. Shivani. Our next panelist is Dr. Gayatri Singh ma'am. Dr. Gayatri Singh is the secretary of Obs and Gynae Society of Bareilly, presented papers in Yuva FOXI, and she's been practicing for over 30 years. Welcome, Dr. Gayatri ma'am. Our next panelist is Dr. Anshumala Rastogi ma'am. Ma'am is a senior consultant at ERA Medical Center, Lucknow. Her special interests are high-risk pregnancy, infertility, adolescent health, and family planning. Welcome, Dr. Anshumala ma'am. Yes, I now hand over the session to Anita ma'am and Preeti Kumar ma'am for and looking forward to excellent panel discussion.
Thank you so much, Shatabdi. At the outset, let me thank, before I start sharing my screen, I would like to thank Priyankur, the chairperson of Public Health Committee, Public Awareness Committee, and of course, Monica for, all her hard work. She has been tracing everybody for last 15 days. So a wonderful coordination. And of course, high regards to Dr. Kamal Bakshi ji and my teacher, Dr. Chandravati madam, and definitely Anita ji, who is also very beloved and member of, I must say, Safe Motherhood Committee, because she initially was there in the Safe Motherhood Committee. So thank you so much. And we have galaxy of learned panelists. So today we will focus more on iron deficiency anemia, and then megaloblastic anemia and thalassemia. So as time permits, we have 40 minutes. We'll go ahead with the slides. And as soon as the time is up, we will stop the presentation. So I'm going to share my presentation right now. So I'll request the panelists to be very crisp in their presentation, in their responses. So am I audible and the slides are visible?
Yes, ma'am. Yes, ma'am.
Okay,
Yes,
okay. So on behalf of this entire forum, Dr. Anita Sabharwal and myself, I welcome all the panelists, and we would like to have your expert opinion on your practices. I want I want clinical answers, not the theoretical ones, and then we will have the expert opinion from Dr. Kavita Bhatti. So as you all are aware that despite Anemia Mukt Bharat Abhiyan, there are a number of states where NFHS5 data shows that there had been an increase in the prevalence of anemia. Like Sikkim, as you can see, from 23, it has jumped to 40.7. Even states like Gujarat, from 51, it has jumped to 62.6. So there are a number of states where, despite all these efforts, the anemia is rampant and the prevalence and incidence of anemia is rising, not only in adolescent, reproductive, but mainly in the pregnant women. So coming to the latest recommendations by Ministry of Health and Family Welfare, these are taken from Anemia Mukt Bharat Training Toolkit. These are the recommendations which have been recently added. One is delayed cord clamping. This is for the baby. Switch from 100 milligram to 60 milligram elemental iron. Initially, it was 100 milligram. Now it is 60 milligram elemental iron. Mandating use of fortified food in public health programs. Special focus on use of double fortified salt, iodine and iron both. Use of invasive digital methods of hemoglobin estimation. I'm sure that many of the centers which are public facilities, they have point of care devices, but many of the private sectors, they don't have the point of care devices, but still whatever method they are using, the hemoglobin estimation has to be done. And now this, besides iron sucrose, ferric carboxymaltose is also in the basket of the treatment of moderate to severe anemia. So coming to some of the highlights that this paper tells us about is, this was published by a Safe Motherhood Committee in our own journal. And we did the survey of our own OBGYNs, 1900 OBGYNs participated in this. And this was the outcome of the paper. 88.7% OBGYN screen anemia in the first trimester, that is good enough. 53.7% OBGYNs performed CBC and along with RBC indices for every pregnant woman. Rest 50% are still doing only hemoglobin estimation. Majority of the OBGYNs estimate hemoglobin only 3 times in antenatal period. 50% OBGYNs do not consider thalassemia screening routinely, that is good enough, but deworming regularly also, they are not deworming the patients. Majority of them prefer low dose iron and they prefer to use 100 milligram oral iron daily. And almost half of the OBGYNs prefer to change the iron salt when the patient is not responding. This is again a major challenge. If the patient is not responding, most of them were switching over to the other salt. Interestingly, 52% of the OBGYNs evaluate serum ferritin before starting intravenous iron therapy. So again, 50%, more than 50% of the OBGYNs are giving iron, IV iron without testing for serum ferritin. 53.5% perform hemoglobin estimation as early as 2 weeks of IV iron therapy. So these were some of the questions that we wanted to ask to the OBGYNs, and this was the paper which was published in 2022 in Jogi. We all know that the total requirement of the iron increases in the pregnancy, and we know how it increases, major from the placenta, the RBCs, the fetus, everything requires iron. So coming to the case discussion straight away, a 21-year primary gravida comes to the OPD with 15 days overdue. Self-pregnancy test was positive. She has mild nausea. After an ultrasound confirmation of the pregnancy, she was advised routine antenatal investigation. Now, when she comes, hemoglobin was found to be 8.5 grams. CBC was normal and GBP shows a microcytic hypochromic picture. So the question to the first Anupma and Vartika is, what will you do next? Will you advise diet or oral iron, or would you like to go ahead with further testing? So Anupma and Vartika, your question, yeah.
So, ma'am, since she has just missed her periods, it would not be advisable to give her oral iron. I would prefer, giving her dietary advice, and she should have iron-rich foods, especially green leafy vegetables. Then good is a very good source. We have dal And in case she is non-vegetarian, then of course fish, liver, meat, that they have very rich heme iron in it. Then she needs to cook in iron utensils. So लोहे की कढ़ाई में अगर वो हरी सब्जियां बनाए, then it would help in increasing and building up her iron. She should add vitamin C to her diet. So nibu is something that is easily available. While she's cooking dal or something, she can add nibu to it. And the other thing would be that she should avoid taking coffee, tea, because these are the ones that interfere with iron absorption. So I think Dr. Vartika can add.
Vartika, can you add anything? You want to go ahead for further testing or anything else you want to add what Anupama has just now mentioned?
Yes, and foods like millets, ragi, they are rich source of iron. They can be added to the diet. Secondly, regarding the oral iron, we don't give oral iron in first trimester because it's seen that because of nausea and gastric irritation. So we would be adding to that. And secondly, the iron absorption is also very less in first trimester. And thirdly, in some animal studies, it has been shown to be teratogenic. So we avoid oral iron. But however, in if it is really required, then only we should give. Otherwise, we have to avoid oral iron intake in first trimester.
Any further testing is required in this patient? In pregnant, any further testing? Would you like to do any further test in this? Besides the routine test, what we do. So we'll take opinion from Dr. Kavita, our expert. Dr. Kavita, suppose her hemoglobin was something around 7.5 or 8 grams, something like that. So can we give oral iron if we want to give, if patient is not having any nausea, vomiting?
Yeah, before I go ahead with the decision of giving an oral iron, so like to see whether she's having thalassemia, because our Indian region, especially Punjab North region, many of our patients have thalassemia trait and or thalassemia minor, as you can call it. So we always screen these neonatal patients. Actually, in our hospital, we are screening everybody in the first visit itself for thalassemia. So we are doing high performance liquid chromatography. If not, then HP electrophoresis. Sometimes you can even detect by the HB indices, or there is something which is known as Menzer's index. So I think I will go in for that first.
Okay. So what I could get is that you are routinely testing for hemoglobinopathies, that is thalassemia, in all the anemic patients. So this was one of the questions in the survey, but 50% said no, we don't screen for thalassemia routinely in all. So let us see what Government of India guidelines say. So I think most of the things are covered. The diet, all palak roti, all green leafy vegetables are rich in iron. So what Anupama said, will avoid telling her that you should not take milk and caffeine. It's not that you should avoid telling her. It's only thing it should not be taken immediately after the food, what she's taking, or because she can take, if she wants to take, she can. You cannot just tell her that you avoid taking this. The only thing is you have to see that when she's taking any iron content in the food, these things should be avoided. And एक बहुत अच्छी चीज बताई थी अनुपमा ने कि नींबू डालना, because this vitamin C increases the iron absorption. तो ये बोला जाता है कि आप आयरन में जब आप नींबू लेना चाहते हैं तो आप खाने में निचोड़ के लीजिए. It is not that when you are cooking you put the lemon. बहुत लोग खाना बनाते समय डालते हैं. It should not be done. And second thing is which I want to tell is जैसे साग वगैरह बनाते हैं ना, तो it is better you wash them before cutting. So काटने के बाद नहीं धोना है, धोने के बाद उसको काटना है. So these are some of the practices that we can tell to the pregnant women or their the attendants who are coming. और ये सारी जितनी चीजें हैं, they all increase the iron absorption in the diet. So this is what is I was telling you कि काट कर ना धोएं. It is always धोएं पहले फिर काटें, because most of the iron is washed out. And you will not get what Ritu just now mentioned, lot of micronutrients are lost when you cut and then wash it. So ये खाना बनाते समय नींबू के रस का उपयोग ना करें. These are all from Government of India guidelines, Anemia Mukt Bharat Training Toolkit. And जितना भी नींबू डालना वो खाना खाते समय डालें. So now next question was, can we give oral iron in these pregnant women in first trimester? So this is a very basic question that most of the times we hear in the panel discussions, and it's a dilemma. So Dr. Kavita, since you are expert, Vartika said she will not use. What is your take on this? Will you use oral iron?
Not really, actually. It's better to avoid it in the first trimester because of the gastritis, vomiting, nausea, and we should actually avoid it. If it is very less, like maybe 6-7 grams, then you may consider if she's able.
May consider giving. So it's usually it is avoided till embryogenesis. But if you want to give, you can give, because there are certain guidelines which say that you can give oral iron in the first trimester. But again, the compliance will be poor, the absorption will be poor. So a lot of issues with the oral iron. So let us see this picture, what Dr. Kavita was telling, and I just wanted to highlight here. Just see that the hemoglobin is 8.8. So I was talking about any further test. So further tests are, you should check the RBC indices. These are very, very important. That will click your diagnosis immediately. So if I show this picture to you, hemoglobin is 8.8. Look at the blood count. RBC count is normal. And rest of the indices, if you see, MCV is low. It's microcytic hypochromic. MCV, when you take the hemoglobin should be more than 11 in pregnant women. So if you call it MCV, the MCV should be less than 80 femtoliters. So in this picture, you see that the MCV is less than 680, that is 63.84. And RBC count is 4.84. So important differentiating feature between thalassemia and iron deficiency anemia is, in iron deficiency anemia, the RBC count will also drop. So if I see this picture, I will immediately call for another test, that is the hemoglobin electrophoresis, to rule out thalassemia, because here the RBC count is normal, hemoglobin is low, and it shows a picture of microcytic hypochromic. So this was pointed out earlier by Dr. Kavita. So I just wanted to show you this kind of a presentation. So whenever you are testing, it is not only hemoglobin, you should see hemoglobin, do CVC, look for RBC indices, and then what you should see is general blood picture. So these are 4 important things that you should do in every pregnant woman. It's not only hemoglobin that you should test. So these are all dietary measures which has been covered by all the panelists. So regarding the oral iron, the practice is mostly avoided due to severe gastric irritation and absorption is low, but practicalities can be given if indicated. It is endorsed by most of the guidelines. Now coming to the second case, she's primi gravida, age 28 years, and she reports at ANC at 16 weeks of gestation. So hemoglobin is 11.5 and everything is normal here. So next question is to Dr. Gargi and Dr. Parul Gupta. Will you give prophylaxis of iron in this patient, because the hemoglobin is absolutely normal here? But would you like to give her a continuous iron or intermittent or low dose iron, or any other measure that you want to adopt in this patient? Gargi and Dr. Parul.
Yes, definitely. We would like to give prophylaxis in this patient, because as the time progresses, as the antenatal age, gestational age progresses, the demand of iron will also increase, as told in the previous lecture. Also it increases to 7.5 milligrams and per day. So we have to give like 60 milligrams of elemental iron and per day, and 180 tablets in the whole pregnancy, even if the patient is not anemic. This is prophylactic dose because of the increased demands of iron.
Right. Parulji, anything else you want to add?
She's already into the mid trimester and she is normal hemoglobin patient. However, with daily diet only, we cannot control her developing anemia later. Moreover, she can be deficient in her stores also. Around 630 milligram of iron is needed in throughout pregnancy, and fetus takes the first iron, whatever is available to the mother. So it goes to the fetus first, then to the maternal.
So the question is that will you give prophylaxis iron, yes or no?
Yes, we have to give.
So would you prefer giving continuous, intermittent, or low dose? What is your choice?
Like India, we would like to give her continuous dose, but if the patient in a dose of 60 milligram
per day 60 milligram of iron and 500 microgram of folic acid. However, if the patient is non-compliant, then we can call her weekly for an intermittent dose, or she's not able to tolerate iron, we can call her for an intermittent dose of 120 milligram of iron and 2800 microgram of folic acid. Per week, we can call her and give it. So she is compliant.
So this is as per the Government of India guidelines. Dr. Kavita, your experiences. Would you prefer giving an alternate day, because the hepcidin levels, it has been shown that even if you give a low dose iron on an alternate day, the response is almost the same if you give a continuous dose. So better if you give on alternate day.
Very correctly said, ma'am, that either you can give intermittent or continuous iron therapy throughout the pregnancy. But in my practice and what we see in our local societies and other hospitals, that we always prefer to advise a regular dose, like continuous dose. Because when you give them intermittent, they might even forget, they may not even consider the importance of taking oral iron. So we normally give this, though Government of India may recommend that you give it for 100 days. Earlier it was like that, but I think they have increased it to 180 days. So this is required, and according to the patient preference, you can take it.
So anything else, Dr. Kavita, you want to add in this? Anything else? So WHO says that yes, you have to give it daily, but intermittent can also be given. Suppose the patient is not able to tolerate daily and she's having a lot of side effects, you can try giving intermittent oral iron along with the folic acid. Then the dose has to be a little bit increased. Now, deworming again is missed by most of the OBGYNs. Can you mute, Monica, can you mute yourself? Monica, can you mute yourself? So deworming again, most of the OBGYNs, they forget deworming all pregnant women. So 400 milligram of albendazole should be given in the second trimester. And then if it is endemic, if hookworm is endemic, then you have to repeat antihelminthic treatment after 12 weeks of first dose. So please try, whenever you are starting iron, please add a deworming tablet, that is albendazole, to all pregnant women. So coming to case 3, Mrs. X, para 2 plus 0, both alive, comes to antenatal checkup and hemoglobin is 8.5 gram. In first antenatal visit, it was 10 gram. So now it has come to 8.5 grams. And the gestational age in this is now 26 weeks. The same patient, now the gestational age is 26 weeks. So what next? Is there any change in your protocol, what you were giving, a one tablet, or any further investigations before starting iron? Dr. Shivani and Dr. Gayatri.
In this case, ma'am, we have to give the therapeutic dose of iron, that is 2 tablets of 60 milligram iron and 500 microgram of folic acid, along with the good diet. Or we can give her, this is the case of moderate anemia. If the patient compliance is better, then we can go with oral iron. And if the patient compliance is not better, then we can switch over to parenteral iron also.
So Gayatri, just want to ask you, how long will you give iron, and then when will you test for hemoglobin again? And if you see the response is not there, then you want to test her again for further, subject her to further investigation. So what is actually the duration? How long will you give her? That is known as the trial of iron.
Yeah, we can give ma'am iron in the therapeutic doses for 1 month, and then again we investigate her. And if the increase in iron is more than 1 gram per 4 weeks, 3 to 4 weeks, then it's okay. We can go for oral iron also alone. Or if the increase in the hemoglobin is not sufficient, then we should investigate for some other causes for anemia, also like inflammation.
So Shivani, anything else? Would you like to go ahead?
Yes, Preeti ma'am. So as you gave us so many clues that she is para 2, that means she's probably depleted all her iron stores in her previous pregnancy, and now she is at 26 weeks, so we don't have that much time, and we should always in such a patient add vitamin C along with when we are giving iron. So I always give 500 milligram tablet, always do deworming, always check vitamin B12 level, and I try to maintain it closer to 500. So I give injectable at least 2 cc of B12 shot, or now you have that 1.5 gram Regunix Fort comes. So you can just give a single shot of B12 also along, because maybe she has, if we cannot afford to do the test, we can just give B12 tablets along with it. And always we must bear in mind that there could be something which is hidden. So follow up after 1 month and recheck of the hemoglobin level and make sure that it is rising, because if it is not, then we must investigate further for maybe some other piles, she's losing blood, or some other reason could be why the hemoglobin is not increasing.
So I think, Shivani, you have touched upon very important and relevant points, because sometimes the thyroid may be a problem. Sometimes B12 is also there. So lot of nutritional deficiencies, even protein deficiencies can cause iron. So it's multi-nutritional deficiencies sometimes. It's not only iron deficiency anemia, but according to the Government of India guidelines, you treat every anemia as iron deficiency anemia unless proved otherwise. You give her a shot of oral iron, as mentioned, 2 tablets for 1 month. And as mentioned earlier by Gayatri, that you have to check hemoglobin after 1 month. If the rise is more than or equal to 1 gram, then you continue with the iron folic acid and check for hemoglobin after 2 months, and then you can switch over to the prophylactic dose again. But again, if the patient is not responding, the hemoglobin rise is less than 1 gram, then you have to check for the further testing for hemoglobinopathies and see whether the patient is compliant, or there's a malabsorption, as Shivani was mentioning, or there can be a chronic infection or continuous loss of iron in this patient. So this is again a picture in front of you, Shivani. Here the hemoglobin is 11.4, which seems quite good for this patient. And if you see why I'm putting this, because it is very important to see the RBC's indices. That is why I'm telling again and again, if you see the RBC count, it is 4.47, which is quite normal. But if you see the MCV and MCHC, these parameters are a little bit on a lower side. So what does that indicate? That means this patient is not iron deficiency anemia, but she can be a case of iron deficiency. Okay, so it is always important not only check the hemoglobin, always check at the hemoglobin RBC indices, and you look at the MCV, MCHC, all these parameters. Here the RBC count is normal, MCV is normal, but MCH and MCHC are reduced in this. And if you check the ferritin, it was 10.50.
Yes, ma'am. These patients also come with sometimes chronic UTIs in pregnancy, recurrent infections or recurrent flu or upper respiratory tract infections.
Yes. So this is what I'm telling is, even if she's not iron deficiency anemia, she can be iron deficient. That is why you have to keep a check on her. And here the ferritin level was 10.50.
Very important.
So I ordered this test because I looked at the RBC indices. They were on a lower side. So I asked for the ferritin level. So this is, again, you have to be very, very cautious that you have to check for ferritin. And sometimes when they come with the recurrent infections, then ferritin will not be a good indicator. Because in chronic infection and chronic inflammation, ferritin may be high. So that may give you a false picture.
False value. So serum iron may be better. And as you saw, vitamin D is also deficient in this patient. So as you mentioned, multiple deficiencies.
Yes. So thank you so much. So what are the side effects of oral iron? What would you normally advise to overcome them? Nidhi and Anshu.
Can I take this question?
Yes, please.
Yeah, so oral iron, although it is very widely available, it is cost effective also. But many of our patients, a sizable percentage, they do suffer from the side effects, and they are mainly gastrointestinal in the form of nausea. They could have abdominal cramps. They could have vomiting also, sometimes constipation, sometimes diarrhea. And then they also have indigestion all the time. And they also complain of the metallic taste. So these are and they are sometimes very, very troublesome, and the patient is just not able to take her oral iron. So to overcome them, what we can do is that we can start with a lower dose. or we could just tell the patient to take it after meals or with meals, so that effect is not so much. We could also sometimes changing the salt. It sometimes helps. So if we see that the ferric salts, if we are giving, so they have a better GI tolerability, but the disadvantage is that the absorption issues are there. So yeah, so these are the main things which we can do.
So again emphasizing that if a patient is taking oral iron comfortably for 1 month and she's not responding, then you have to check the causes, whether she's a hemoglobinopathy or she's still iron deficient, then you have to switch over to IV iron. But if she's not tolerating, then you can change the brand. It's not that after 1 month the patient is not responding, you change the brand. It should not be done. You should switch over to other iron preparation, IV iron, or look at the cause why she's not responding to that. Nidhi is there? I think Nidhi is not joined. So coming to case 3, after that, Anita ji will take over. So 32 years, Gravida 3, Para 2, rural women, twin pregnancy, comes at 34 weeks of gestation, and hemoglobin is 8.5. And taken oral iron given at some PHC, and her investigation shows microcytic hypochromic, and it's a iron deficiency anemia, clear-cut iron deficiency anemia. The gestational age is 34 weeks. So coming to Anupama and Vartika again, what would be your modality of treatment in this patient? Would you like to give oral iron in this, or you would like to give blood, or would you like to give IV iron? And what are the advantages and disadvantages of various modalities at this stage?
So, ma'am, according to Anemia Mukt Bharat, she's already 34 weeks and she has twin pregnancy. This is her second pregnancy. So, since she's completed 34 weeks, I would prefer giving her parenteral iron, either IV sucrose, which is 300 milligrams twice a week, or she can take ferric carboxymaltose, which is 1000 milligrams once a week.
What do you prefer?
On the
Anupama, what do you prefer?
Ma'am, ferric carboxymaltose.
Okay.
I would prefer that.
Okay,
So,
so you told us.
Since you have already mentioned that she needs to be dewormed, I think that is a very valid point. We all must keep that in mind. So give her an albendazole as well.
Okay. So Vartika, anything else you want to add here?
Ma'am, I would go for parenteral iron and FCM only in this case. And we will rule out any, like while giving FCM, though FCM is safer than iron sucrose and there are less chances of anaphylactic reactions, I have to rule out any active infections, whether they are present in the patient, any history of liver disease, or if the patient is having some renal failure, or thalassemia has to be ruled out, because in iron overload conditions, parenteral iron.
So ferritin is the best indicator, provided there is no inflammation or infection. So Dr. Kavita, coming to you, gestational age more than 34 weeks. Suppose the hemoglobin is 10 gram, not 8.5, maybe 9.5 or 10 gram. Still, you would give oral IV parenteral iron or oral?
No, if she's around 9-10 grams, then I would still counsel her oral iron, because the percentage of rise of hemoglobin with oral iron and parenteral iron is almost same. It takes about weeks. And if she's a knowledgeable, compliant patient, then I can go ahead with oral iron.
With the oral. So for mild anemia, you can consider giving oral, but although Government of India guidelines say for mild to moderate, gestational more than 34 weeks, always switch over to IV parenteral iron. Or if the gestational age is less than 34 and patient is non-compliant to iron, then oral iron, then you have to switch over to parenteral iron. So, Dr. Kavita, is there a routine practice of doing ferritin levels before giving IV iron or not?
Ideally, you should, but many times we skip that.
We skip that. Okay.
Ma'am, even cost is an issue.
Is a cost. So Dr. Kavita, yours is a big hospital, I think tertiary hospital. So private hospital. So what do you prefer, FCM, or you give FCM should not be given in first trimester. That's any IV iron should not be given in the first trimester. So you prefer giving iron sucrose or FCM?
We give iron sucrose.
Iron sucrose. Okay, still iron sucrose. Okay. So Dr. Parul and Dr. Gargi, coming to you. What are I think we have discussed about the two preparations. One is IV iron sucrose. These are two recommended ones, and ferric carboxy maltose. Anything else anybody wants to add here?
We would prefer iron sucrose because it is cost effective and brings the hemoglobin as well.
But the problem with this iron sucrose is that it has to be given only 600 milligram in a week. That is 200 milligram alternate days should be given, not more than that. That is very clearly mentioned in the Government of India guidelines. So you should not give, so patient needs to be called again and again. So for FCM, you can give it in one shot. So that's the only beauty of this ferric carboxy maltose. Anything else, Dr. Kavita, you want to add here?
I think it's been covered from my.
It's covered. So just I want to highlight here, Shivani, can you just tell us how to calculate the total dose of iron? This is very, very important because once you're giving an IV iron, you should calculate the total dose. That's very important. So Shivani, coming to you, how do you calculate the total dose of iron?
I think standard, the formula of Ganzoni is used where you have 2.4 into target minus actual HB, and target HB I've seen in some studies, they even take it as 15. So you can take the target HB that you want minus actual HB and multiply by her pre-pregnancy weight. And you must always add 500 milligram to replenish the bone marrow iron stores. And actually, we rely on how much preparation we have available. So we have like 1000 milligram of FCM available. I am almost exclusively using only and only FCM because our patients don't like to come back again and again. For them, time and taking that IV is a big, they are afraid of needles. So I'm using 1 gram. And in fact, I have seen that many times it happens that we have to repeat the 1 gram dose also in pregnancy. So it is not just that 1 gram. And when I was studying literature in preparation for this, I saw that there are some studies which are saying that 1.5 is actually because 1 gram is for the pregnancy plus 500 for the store. So just one FCM 1000 is also not enough sometimes.
So suppose Shivani, you have given a total dose. Would you, after how much time will you start the oral iron?
Ma'am, it depends. Like if you have given FCM 1 gram, then you would probably want to wait for a month. But at least first you have to omit the oral iron when you're giving oral. And I will wait for at least a week. But sometimes I would even omit it for a month and recheck hemoglobin next month and then decide.
Okay, Gayatri, what's your take on this?
I think there is no need of oral iron after parental iron. After giving parental iron.
No, there are people who are really iron deficient.
So, let me come to this now. Again, this is Ganzoni formula. Let me clarify again what Shivani has just now mentioned.
Because
it's the target hemoglobin here is 11. Very clearly mentioned in Anemia Mukt Bharat training toolkit. It's not 15. Remember, it is 11 for pregnant women. It is for the 15 or 14 is for non-pregnant patient. It is for pregnancy, the target hemoglobin is 11 minus actual hemoglobin, and it is not 1000 milligram replenishment of the stores, it is only 500 milligram. So once you calculate the dose and then you give a total dose of iron, and once you have given a total dose of iron, then you need not to replenish it with the oral iron. So it is very, very important, and it is mentioned in the Government of India guidelines that if you have given a IV total dose of iron, no further need of prophylactic IFA tablet if hemoglobin is more than 11 gram%. So this is what is written, and as rightly said by Shivani, you have to stop oral at least 24 hours before giving IV iron, and then give a total dose of iron. Always calculate the total dose. So whatever is the calculate, because we give half of the dose. We give 500 milligram, call her after some time, again give her 500 milligram, and we are not actually calculating the total dose. So Ganzoni formula is important, and there is a beautiful chart in Anemia Mukt Bharat training toolkit where you can just mention the weight of the patient and the hemoglobin, and you get the how much iron is required. So this is all about this thing. And Anshu, can you just touch upon the side effects of IV iron? Then I'll hand over to Dr. Anita.
The side effects of the IV iron, sometimes the patient can have nausea, like she can have hypotension, she can have tachycardia, she can have chest pain, sometimes dyspnea, sometimes edema, sometimes swelling, So I personally encountered this in one of my patients in which I had given iron sucrose. This was around 6 years back. So first dose I had given, and the second dose I had repeated after 3 days. And with the same brand, she developed swelling of the mouth and, difficulty in breathing. But luckily, so what we should do is that it should always be given in a hospital setting with proper monitoring. A person has to be there, and initially when you start, it should be slightly slow. And once some time has passed, you can increase the rate. So these are the precautions that we should do. And as you mentioned, that
So just
24 hours
quickly,
prior,
because
you should
Dr.
stop
Anita,
oral.
yeah, okay, thank you so much. Whenever you are giving a IV
Dr.
iron,
Preeti, please go on. There's no issue.
no,
Go
no,
on.
no.
Complete your,
See, if you are giving a IV iron, there are side effects. Please mention in the adverse drug reaction form. There should be adverse drug reaction form. You have to mention about the side effects. It's very important. And why the iron is not given for a longer period of time? Because if you take a longer period, more of labile iron will be released, which is more toxic and causes a lot of side effects. So coming to the next question, I think Dr. Anita can take up. What are the other indications? Dr. Anita, you can go ahead. I'll move on slides.
So to complete this one, I'll go with the next case only.
So
Preeti,
what are the what are the
Yeah.
other indications for administering parental iron?
So if the patient is absolutely non-compliant with taking oral iron, we can switch on to parenteral iron after doing a hemoglobin repeat. Or if she's not able to absorb the iron because of some gastrointestinal problems, like there is an inflammatory bowel disease, or there is a malabsorption syndrome, or she's had a gastric bypass surgery, or there is vomiting, or if we are doing a postpartum hemoglobin and she's bled, or her hemoglobin postpartum is below 10.9, we can give her IV iron because she may be lost to follow up. So we have to prepare her for the next pregnancy as well, and the lactation as well. Also in cases where there are inflammatory diseases like renal disease or liver disease or cancer maybe, in these cases we can give her IV iron so as to keep her
quite frequently used IV iron. So Dr. Kavita, what is the routine practice of giving postpartum IV iron in your facility?
Yes, we do give, especially patient we know that is not compliant, is not going to come back to us and will not have a regular checkups in the postpartum period. But most of our patients, they continue with the oral iron therapy for 3 months. So Government of India has recommended up to 6 months, I believe.
So do you have any experience of using isomortoside, which is a new molecule which has come up?
No, we haven't used that yet.
Okay. So Dr. Anshu, is it mandatory to do HPLC before giving IV iron? I think this has been talked about. We should
Yes, I think so.
ferritin,
It is very necessary
this should be,
because IV iron should not
so
be given
coming
in
to thalassemia, I think Dr. Anita, you can.
Yeah, this is parental therapy. You just touch upon, and then I'll go to the next case because
So
we'll
in
be talking.
thalassemia, beta thalassemia patients, again, oral iron, if documented iron deficiency, then only it has to be given. Parental iron therapy should, because they are iron overloaded. So it is very important to test for the iron deficiency, check for ferritin. If it is low, then only give iron, either oral or parenteral, whatever is needed. But for beta thalassemia major, any form of iron supplementation is contraindicated. Now coming to case 3.
Yeah, thank you. Thank you so much, Dr. Preeti. You've been such a pillar of strength, and with wonderful slide presentations, I've been given the opportunity to be part of it. Thank you so much. Now, another very interesting case. This is 25 years young lady, Gravida 3, Para 2, L1A1, and she's at 24 weeks of gestation with hemoglobin 8.5. And her picture you can see here. It's anisocytosis, dimorphic anemia as per the peripheral smear. You can see serum iron, serum ferritin, and the total iron binding capacity, which seems to be increased, whereas other levels are decreased. And also even you can see transferrin saturation. All these levels you can see here in the slide. So what is your diagnosis after you see? I'll go to Dr. Shivani and Dr. Nidhi. What is your diagnosis and how do you say it is so?
So, Dr. Anita, I think the diagnosis already written there is dimorphic anemia. As we can see, this is mainly folate deficiency, B12 deficiency, and iron deficiency anemia. So it is a combination of iron and megaloblastic, and MCV is not reliable in these cases because it is going to have between iron deficiency and megaloblastic, you cannot use MCV as the reliable indication in this case. And the treatment for this patient is going to be supplementation.
We'll go to that the next question to somebody else. That was the only thing rightly you said, that we could diagnose as iron deficiency as per the picture, as you really clearly explained. So now the next thing is, how would we start this treatment? And because this patient is in mid gestation and she has moderate iron deficiency anemia, as well as you said, she has megaloblastic. Now, because of now this part, iron deficiency anemia, what is the dose of iron and how we will manage this part of anemia? Dr. Parul, Dr. Anupama, please, both of you comment on this.
Yeah, so we'll start with 60 milligram of iron and 500 microgram of folic acid along with B12, which is around 1000 milligram per day we'll give her to treat both the types of anemia. And this has to be given twice a day. 60 milligram and 500 has to be given twice a day in order to treat this anemia. And if she is not responding, as we've seen, then we will switch over to parenteral or otherwise. That is a later part of treatment.
Albendazole फिर भूल गई.
Albendazole has to be given to all patients.
Yes. So very rightly, as you mentioned, and as per Anemia Mukt Bharat also, we are managing this moderate anemia, which is from 7 gram to we can say 10. Yeah. So what is on now? We will go to Dr. Gargi and again Dr. Shivani. Now we will be treating the other part of this anemia. So megaloblastic. So dose of vitamin B12 and whether we are giving oral or parenteral, which case, and what should be the duration and how will we assess the improvement, because it's going to be both B12 and folate also. So Dr. Shivani, Dr. Gargi, both of you can say.
So for vitamin B12, generally I am using both oral supplementation or intramuscular. It depends on the degree of deficiency and the symptoms that the patient is experiencing. Intramuscular is 1000, that is 2 cc of the injection once a week. Generally 2 injections are sufficient for the deficiency, and after that, if required, you can give a low dose like a B12 supplementation in a month. Or alternatively, as you have mentioned, oral dosing equally effective, 1000 microgram orally once in a day. And as for folic acid, there are many preparations which are available from 400 microgram to 1 milligram to even up to 5 milligram per day. And so these are quite sufficient because they are having enough dose to rectify the folate deficiency. And sometimes, as I said, the picture in the blood can be confusing. So we must always bear this in mind and give both the supplementations together and not miss out.
Yeah. So very rightly you mentioned that. But now one very tricky thing is, because both this, if you give folate, it can manage a lot of symptoms of B12 deficiency also. But now how we can, manage this part, because there is masking of B12 deficiency by the folate. Can you comment on that?
Yes, I think, yeah, you have mentioned about the neurological manifestations.
Yeah.
What I see clinically in practice is a person has a lot of gastritis and digestion problems, and that's how you know that B12, that is the #1 cause of that. As you rightly mentioned, there are neurological complications also.
And most of the times when the patient are on H2 blockers, like they are taking lot of antacids and lot of H2 blockers, they land up in these kind of deficiencies.
Exactly, and they can come up with even ulcers and perforation of ulcers just for stomach pain for B12 deficiency.
Yeah.
Yeah. Right. So we can mask untreated B12 deficiency. So that really has to be taken care.
Gargi, do you want to add anything? Gargi was supposed to.
Yeah, Dr. Gargi. Dr. Gargi, what are your comments? Is Dr. Gargi there?
I don't think.
Huh?
She was there.
I think she's not around. Even I couldn't see her.
Okay.
So now I will like to ask Dr. Kavita
Yes.
from my alma mater, your expert comments. What are the risk factors which can predispose to megaloblastic anemia, and how often you see at CMC Ludhiana?
Yeah, we are seeing this very often actually. I think we are seeing more of dimorphic anemia rather than isolated iron deficiency anemia. And I would stress that we should be looking at the blood film also, because many a times we miss that, and we do not diagnose these dimorphic anemias and do not give the actual supplementation with vitamin B12 and folic acid, which is required. So in megaloblastic anemia, you can see the macrocytic cells, which are larger in size. Sometimes you can see hypersegmented cells also, neutrophils. So from the blood film also, you can gather a lot of information. And very rightly pointed out by you, ma'am, that there are so many causes for folic acid deficiency and vitamin B12. There is something which is known as pernicious anemia also, that is because of an autoimmune problem when the intrinsic factor is missing. So leading to malabsorption of these vitamin B12 and vitamin B9 and other vitamins also. So one has to be vigilant about these causes and find out the true cause of anemia and then manage accordingly.
Right. Thank you so much, Dr. Kavita. And I think antacid is a very, very common thing which every person is taking. So that was a very important cause of that. Now, next case is unbooked case. So this woman is 33 years old and she's gravida 4 with 3 previous vaginal deliveries, and she comes at midnight.
I think we'll take this as a last case, I think.
Okay. So labor pain since last 6 hours, and she comes with symptoms of cough and breathlessness. And on examination, she's very pale. Chest shows basal clefts, and she has tachycardia of 120 per minute, and upper abdomen. So gestational age is 40 weeks. Fundal fetal heart sounds are only 100 per minute. Abdomen is very tense, and per vaginal, she's 7 centimeter dilated. There is a caput of 2+, and head is at -1 station. So I'd like to ask Dr. Vartika, Dr. Gayatri, what is your presumptive diagnosis and what is the plan of treatment?
Ma'am, this is, sorry.
Yeah, Dr. Vartika, go on.
Yes, ma'am, she is multi-patient, and with the, as we can see, she is unbooked and with lot of pallor at 40 weeks. And she's having labor pains in 6 hours and with cramps and breathlessness. So since with the breathlessness and basal cramps, and there is, I think she's a case of impending cardiac failure with fetal distress and some element
obstructed
of
labor.
yes, obstructed labor, cephalopelvic disproportion maybe.
Obstructed labor and congestive cardiac failure is the diagnosis.
Yeah, so we will be managing, or we'll be calling for help, getting ready with all our team of anesthetists, pediatrician, and we'll immediately put the patient on proper position and start oxygen. We'll catheterize. 2 wide bore cannulas would be given simultaneously. A quick history and examination would be taken. Sample for blood group typing, CBC cross matching would be sent. Then we will also evaluate the fetus, the continuous CTG monitoring. If ultrasound facility is available, then quick ultrasound to see for the parameters, and accordingly, this would be managed.
So it really looks like a grave emergency, and before coming to a diagnosis, immediate, as you said, the first line emergency management has to be done, and then we go ahead. So now, after doing all this, the emergency hemoglobin was done, and which was only 5 grams. So what should be done now? Dr. Anupama and Dr. Nidhi to comment. What should be done now? Hemoglobin is only 5 grams in this patient.
Vartika.
Anupama. Okay, ma'am. So
Yeah,
she's
Dr.
5 grams. She's 5
5
grams.
now.
Is she in failure or is she not in failure? So considering that, her hemoglobin is so low, the first thing would be to arrange packed RBCs for her and transfuse. And after that, that would be under diuretic cover. And we need to give her oxygen by mask. Then we need to find out why her hemoglobin is so low. I mean, is this a case of obstetric hemorrhage? We need to find out the cause for her obstetric hemorrhage, and we have to, do a multi-speciality treatment for this patient, keep an anesthetist in place, and inform the blood bank, have the ICU team on board, and then, find out, correct her anemia. It is important that we should not rush in blood, because then also she can go into failure and she can go into volume overload. So if there is any other infection that we are missing, we need to optimize that, and we need to treat her accordingly.
Documentation and consent.
Very
Yes,
rightly
that is very
said.
important. Documentation and consent. Without that, we cannot go ahead.
Absolutely. And you said packed cell volume, which was very important because we shouldn't be giving whole blood. Otherwise, the patient would be overloaded. So now next is, what are the indications of blood transfusion in pregnancy? Dr. Avartika, Dr. Anshumala.
So it depends on the gestation of the patient. So if the gestation is less than 36 weeks, and if the hemoglobin is less than 5 gram%, so, or even without, if there are no clinical signs of cardiac failure or hypoxia, or if the hemoglobin is between 5 and 7 gram%, but if the patient has an imminent cardiac failure, or if there are clinical evidence of hypoxia, we'll still transfuse. And we should also look out for any infections like pneumonitis or pyelonephritis, or if the patient has malaria. In these cases, we have to transfuse blood. If the gestation is more than 36 weeks, then our cut limit is 6 gram%. And if the hemoglobin is between 6 and 8, and if the patient has evidence of cardiac failure or hypoxia or infections, pyelonephritis, pneumonitis, or any other, then we have to transfuse blood. If we are planning an elective cesarean section and the patient has had a history of antepartum hemorrhage, or even in previous pregnancy she had PPH, or if she's a case of previous cesarean section. So if we look at the hemoglobin, if the hemoglobin is 8 gram%, then we arrange and cross-match 1 unit of packed RBCs. And if the hemoglobin is less than 8, then we have to keep 2 units fresh cross-matched blood ready.
Right, very well said. So I think we are through this. Any special precautions now in this case during second stage of labor, and also soon after delivery, in the immediate post-delivery period? Any special precautions? I like to ask Dr. Shivani and Dr. Parul. Are you there?
Yeah, I'm there.
Okay, Dr. Parul, please go on.
In the second stage, as well as the first stage also, we have to take special precautions for her very nicely. We have to keep the input-output chart, and we have to give intravenous fluids very judiciously to this patient. We have to give her antibiotic. We have to keep her in propped up position in the first and second, both stages of labor. We have to give her adequate oxygen, and the patient does not need to be in very much pain. So adequate analgesia has to be there. And we watch for pulmonary edema as well. And we have to cut short the second stage of labor, either by forceps or vacuum, or maybe if she requires cesarean, it should be done only for obstetric indications. And in the third stage, we have to cut short the third stage by active management of third stage of labor, because so as to minimize the blood loss. Also, we have to give her, obviously, injection oxytocin 10 units intramuscular is right, because we cannot give her many oxytocics. And umbilical cord clamping should be delayed for the baby, not for the mother. And any postpartum hemorrhage has to be energetically treated for this patient.
Right.
And I think we have to add injection Lasix also in the second stage, because that is a time when they're more prone to go into congestive cardiac failure. But this patient, I think she's already in congestive.
Already in congestive cardiac.
Better to
Already
release.
managed. Yeah. So during now the post-delivery period, again, we have to take precautions. So can Dr. Shivani throw some light on that? Dr. Shivani, are you there?
I think she has left.
Okay, Dr. Parul, please go on.
Yeah.
So with this, I think, Dr. Anita, this would be the last slide, then we will close. Huh?
Yeah, okay, fine. So this is very important slide. Yeah, so please go on, Dr. Parul.
Yeah, we have to ensure that she's on rest. And later on, she will be advised iron-rich diet if she's already been given some blood transfusion during labor or pre-labor. And iron folic acid therapy should be continued for at least 6 months, not 3 months. Just Government of India advises 6 months post for store replenishment. And any infection should be prevented by good antibiotics. And we should check for any infection. If she occurs, lactation failure could be there, subinvolution of uterus could be there, and thromboembolism rarely could be there. So we have to check, we have to call her regularly, postpartum also, and contraceptive counseling is very important in these cases. She should not become pregnant very soon.
So at least you give PP IUCD in this case.
Especially in this case, you know, she's already had 3 deliveries. This was the 4th one. Yes. I think now she should stop it. And also now we can explain to her the importance of antenatal care. She was an unbooked case. That is why she landed up in such a bad situation. So I think that must be, yeah.
Any comments from Dr. Kavita?
Yeah,
Yes,
Dr.
because
Kavita.
Dr. Anita was saying that she should put a stop now for further children. So permanent sterilization, I would rather take hold of the husband and advise him vasectomy.
Male, yeah.
That's very important. So
right,
this
very
was
right.
expert comment.
Right. Absolutely.
So
So thank you so much. Yeah, Dr. Preeti, for the wonderful slides and such a great panel. I think we all had a real
Panelists
learning
were
experience.
well read.
Yeah,
They were all prepared, and expert was, like expert.
Absolutely, each one of them.
So
Thank you so
important
much
thing
for the
in this
great
case,
learning.
severe anemia
Yeah.
is you should avoid giving methogen, even the smallest bout
Yes.
of blood loss, maybe a PPH in
Yeah.
this case. So you have to be very vigilant in the postpartum period because anemic patients are more prone for PPH. So you have to be very careful. So drugs like carboprost should be given with caution. Carbitocin also should be given with caution because these are all, she's in congestive heart failure.
Right.
So this can
Absolutely.
precipitate.
The
So
management
these are
of
certain
third
things
stage.
that need to be, looked at.
Yeah.
So thank you so much once again, Monica and Dr. Anita.
Thank
you so
you.
much.
Dr. Vidhu is there.
And
Welcome,
all-
Dr. Vidhu. I didn't see you.
And all the panelists, you all did a wonderful job. Monica,
Thank you.
sorry, we exceeded a little bit, but anyhow, we.
No, ma'am, we are pretty much
Thank
in
you,
time,
ma'am.
ma'am, not a problem.
We managed to wind it up.
Yes.
Yeah.
Ma'am, thank you, Preeti ma'am, and thank you, Anita ma'am. I would request Vidhu ma'am to kindly give her vote of thanks, please, ma'am.
Yeah. Vidhu, unmute yourself. Dr. Vidhu, unmute. Yeah.
Am I audible now?
Yes, ma'am.
Yes.
Sorry for joining late. I was just caught up in an emergency, but I've learned a lot after listening from whatever breastfeeding, especially and about anemia. And I thank our president, Dr. Pai, for his vision to fight against anemia and spread awareness as to build Anemia Mukt Bharat. And also thank Dr. Madhuri, our general secretary, for always being there for us and guiding us. And thank you, our guest of honors, Dr. Kamal Bakshi ma'am and Dr. Chandravati ma'am. And another thanks to all Dr. Preeti, Dr. Anita, Dr. Ritu, Dr. Kavita, and Dr. Ashma and Dr. Jyoti for sparing time and guiding us. And I also want to thank all the chairperson and panelists for sparing the time and giving their valuable inputs. Thank you, Priyankur, and the Public Awareness Committee, and our conveners, Monica and Shtabdi, for organizing this wonderful session, which is a very, very day-to-day practical program, especially about anemia and breastfeeding. And I hope everybody has enjoyed and learned a lot from it. Thank you once again.
Thank you, Vidhu.
Thank you so much.
Thank
you.
Thank you, everyone. Thank you.
Thank you. Thank you. Namaskar, ma'am.
Bye-bye.
Thank you.
Good night.
Okay, bye-bye.